Good afternoon. I'm Kirsten Singleton, Executive Director of Education and Professional Development, and on behalf of the Massachusetts Health and Hospital Association, welcome to today's virtual conference, Population Health and Data Reporting Strategies in the Era of COVID-19. A few logistics before we start. We will be recording this session for those who aren't able to join us, and all lines will be in listen-only mode. If you have questions during the webinar, please enter them into the chat feature. The questions will come directly to us, and we'll do our best to address as many of them as we can during our time today. Following the webinar, we'll be sending out a brief survey. This timely webinar will take a look at the power of and the need for good data. In the wake of COVID-19, Massachusetts hospital reporting tactics underwent a massive transformation as health systems raced to move from retrospective to real-time reporting of key metrics such as bed availability, PPE burn rate, and inventory of nasal swabs, reagents, ventilators, and medications. These insights were critical to public health administrators working to coordinate a statewide response to the pandemic. As case counts across the state began to climb, and with the possibility of another surge, it is critical that hospital and public health leaders consider additional reporting systems and strategies that will better prepare the healthcare system. During today's roundtable discussion, we will discuss these issues among others. Before we start, I'd like to thank Dimensional Insight, an MHA Gold sponsor and partner on today's event. Kathy Suchik, Vice President of Marketing, is here to say a few brief words and introduce our moderator. Kathy, I'll turn it over to you.
Thanks, Kirsten, and good afternoon. Welcome to our webinar. As Kirsten said, I'm Kathy Suchik from Dimensional Insight, a sponsor of this webinar with the Massachusetts Health and Hospital Association. Over the last several months, we at Dimensional Insight have worked with our healthcare clients to help them gain greater insight into their COVID-19 data and make better decisions that positively impact patient outcomes. We have assembled a tremendous panel today with some of the brightest minds in Massachusetts healthcare to talk about the data challenges they faced during the first wave of COVID-19 in the spring and many of the lessons they learned. We hope this discussion will be useful to you and your organizations as COVID cases are again surging across the country. Our panel is being moderated by Jeff Becker, Senior Healthcare Analyst at Forrester Research. Jeff, take it away.
Thank you, Kathy. And thank you to our virtual audience for joining us today. I'm honored to be moderating our session today with an incredible group of my own local Massachusetts care providers. It's genuinely an honor to take the stage with such an esteemed group. And really, before we get started, I did want to take a moment to just thank each and every one of these panelists for taking time to step away from the critical work that you and your teams are doing to help our community during this pandemic. Your selfless service inspires us, and we're excited to learn from you today. So I thank you each. And so now it is my great pleasure to be able to introduce you all to our panel today. First, we have Elizabeth Johnson, Chief Medical Officer at Beth Israel Lahey Primary Care. Peter Dunn, VP of Procedural Services, Healthcare Systems Engineering, Capacity Management, and Mass General Hospital. Kyle Savahi, Department of Anesthesia, Critical Care, Pain Medicine at Mass General Hospital. Anu Puri, Executive Director and Chief Data Officer at Massachusetts Health and Hospital Association. And Thomas Skornavaka, Chief Medical Officer, Population Health at UMass Memorial Healthcare. Now, before we hear more from our panelists, we would actually like to hear from you. What are some of the most significant data analytics issues that your organizations have faced during this pandemic? You're going to see a poll presented momentarily if you don't see it yet. And while we begin opening remarks from our panelists, you can take this time to let us know. Now I'm going to turn it over to Dr. Puri for opening remarks.
Thank you, Jeff. Good afternoon, everyone, and thank you for joining us. I am delighted to be here amidst this distinguished panel of experts. As Jeff said, I am the Chief Data Officer at the Mass Health and Hospital Association. I've been at the association for just under 2 decades, working on a variety of data and policy analysis issues, but for the past, I would say, 6 to 7 months, it's been all COVID all the time. To begin with, if I may, I'd like to start by extending my heartfelt appreciation and gratitude to the frontline workers and first responders throughout the state who work every day tirelessly to tackle this pandemic, as well as to those working in labs to find a way out of this unprecedented situation. As those of you who are, I'm guessing, are attending this webinar know very well, there is no dearth of data on hospitals collected and reported within Massachusetts. Two agencies alone, CHIA and HPC, collect data and report it out on a variety of hospital metrics, including price variation, reimbursement, payer mix, financial performance, case mix, and utilization. And in fact, hospitals submit on an annual basis a detailed cost report that used to be over an inch thick when it used to be printed on paper, that has detailed cost accounting information, but most importantly for this conversation, and I will come back to this later, it also includes detailed information on bed types, bed availability, and occupancy. And of course, in addition to CHIA and HPC, there are other agencies, including DPH, DMH, and Mass Health, that collect their own data. So what I would like to do when it's my turn to speak today is to describe how even in a data-rich state such as ours, when we found ourselves in February facing this unprecedented situation requiring massive priority shifting and mobilization within hospitals, a certain amount of priority shifting and mobilization was also required in the data world. And that's the journey I hope to take you through today when I get a chance to talk about it. Thank you, Jeff.
Thank you, Dr. Perry. Dr. Dunn, any opening comments?
Sorry, I was just coming off mute, and I also want to thank everyone for the kind invitation to join the rest of this panel, and for all that are here gathered to help each other learn from our experiences. It shouldn't be just the panels, but hopefully we'll learn from those who are asking the questions and their experiences as well. But we're happy to share what we at Mass General had done, not just here at Mass General, but also across our entire system, which is the Mass General Brigham Health System. And in addition, we then became part of what was a citywide group with members from the BI, Tufts, Boston Medical Center, Stewart Healthcare System, and other members both from MHA and Department of Public Health and EMS. So happy to share those experiences and look forward to the conversation.
Excellent. Thank you, Dr. Dunn. And Dr. Savavi?
Just echo the same sentiments and really appreciate you having us here.
Excellent. And Dr. Skornavaca?
Yeah, great. Thanks for having me. I think that we're excited to share some of the initiatives that we've been working on at Central Massachusetts as a whole, and really want to focus in on the post-acute world where, almost daily on the news, we're hearing about skilled nursing facilities and some of those type things struggling early on in the course of the pandemic, and kind of the approach we've taken and leadership role in collaboration with them to try and make sure we're able to work more closely as this next version of the virus starts spinning through our communities.
Fair enough. And Dr. Johnson, any opening thoughts?
Thank you so much. I would echo how pleased I am to be with everybody today, and in particular look forward to hearing and learning from colleagues across the state, and hopefully sharing a little bit about what Beth Israel Lahey Health has done during a crisis down in the primary care level, and how we really had to urgently and critically use some data to help us do an initiative that has really significant impact in our patients' lives. So look forward to sharing that story.
Excellent. Thank you, Dr. Johnson. And now we can turn our attention back to our poll results. And what we see, I think, is largely reflective of some of the experiences we will hear about today during our panel discussion. Significant issues, sharing data outside of the organization across ambulatory, acute, and post-acute care. Dr. Skornavaca just mentioning that's an area that he'll be focusing his conversations. Meeting state and federal public health agency reporting, also being raised as a high-level issue. So these are all issues that we'll be asking about and tackling throughout the panel discussion today. Moving into the discussion, I'd love to start with you, Dr. Puri. What was the state of hospital reporting prior to the pandemic? And how did you work with local hospitals to improve on reporting?
Thank you, Jeff. So as I already mentioned, there is a plethora of data being collected. And early on in February, when it became clear that we were going to get hit with the pandemic, and we wanted to, at a state level, understand the level of resource constraints and strains that we would face in terms of ICU beds, medical surgical beds, ventilators, PPE, supplies, and so on, we turned to some of that data. I think my co-panelists will be able to talk in much more detail about what projections they did at a hospital or system level, but at MHA, our attempt was to make some high-level predictions. So early on, what we did is that we took some of the early data coming up from China and Italy on bed use rates, ventilator use rates, and so on, coupled it with census data, and then we took the bed data from the cost reports that are maintained by CHIA, and we made some initial projections, and needless to say, they were very concerning. But the bottom line was that we realized that we were really hampered in our ability to make accurate projections because the bed data and the occupancy data we were using was 2 years old. So even though the cost report is a very useful database and we always tap into it, but it does take a while before data is available. So we're using 2018 data to make predictions about bed needs. And the other piece of it is that the way that beds are reported in the cost report is it can be confusing and inconsistent. So we have licensed beds and weighted average staff beds and weighted average available beds, and not everybody always is able to report in a consistent and complete manner. So our initial projections were worrisome in terms of the bed deficits. And we know that at the same time, the command center, the state command center was conducting its own similar analysis. And eventually, as you all know, this galvanized an effort to create surge capacity within hospitals, to create field hospitals, as well as eventually led to a suspension of elective services statewide. But what became very clear to us is that we really needed to have more current data on bed availability and occupancy, and we needed it to be accurate, complete, consistent, and clear in order to be able to do meaningful projections and capacity planning and provide data back to our hospitals so that they could track that. So initially, we were contemplating creating a daily survey that MHA would essentially push out every day and have the data come back to us, and then we would turn it around and give it to our members. But luckily, early on, we were able to partner with the state government and leverage an existing system that they have known as the Web EOC, which stands for Web Emergency Operations Center, stood up by FEMA to be an online tool for resource management and information sharing. It had been used occasionally for bed drills, but not in the level of detail that we were going to need. Very, very grateful to the state they made the effort to repurpose that online tool to start collecting meaningful data for the first surge. So we quickly set up a new set of questions to ask on a daily basis and started to get people to report. At the same time, we set up a daily call between hospitals and MHA and the state so that we could start answering questions as they came in, and they started coming in fast and furious because every question that we added, we ran into definitional issues. We needed to make sure it was as clear as possible because I don't need to tell the audience the nuances of hospital operations is pretty complicated. But by mid-April, we had stabilized our questions. We had 100% compliance, and at least among the acute care hospitals, and we were able to turn this data around and give it to our members. And then the federal government stepped in. So initially, the federal government would make ad hoc requests for data that was directly linked to distribution of relief funding, clearly a very important thing for all our members, and then also linked to the distribution of remdesivir. But very quickly, that evolved into a daily federal reporting requirement. Up until now, we were talking about a state requirement. Now we had a federal daily reporting requirement, and their definitions were slightly different from the ones we were using. And so we eventually was decided that we would all just transition to that. If you also recall, there were several different ways to report to the federal government. There was the old CDC portal, which was later taken down. There is the teletracking/HHS portal, which is still live. And then the third option was to do this in partnership with the respective state governments, which thankfully is the way that we chose to go. And I will talk about how that partnership has really helped. And then one day in July, and I always remember this day because overnight almost, the federal government added another 60 or so metrics that had to be reported daily. So there was a huge scramble to make sure everyone knew what to report and how to report and what the definitions were. And that was an interesting day. Those questions that have now been reported since mid-July are still being reported, but the process continues to evolve. Some metrics are no longer reported daily. New metrics are being added. Most recently, the federal government wants to look at co-occurring flu and COVID. So those questions have now been deployed, and the definitions are continually being refined. Another key thing that happened recently is that the provider types that are required to report has expanded. So now we have all post-acute hospitals and psych hospitals are required to report, albeit not at the same frequency as the acute care hospitals. So where are we today? So our acute care data set and the reports are fairly stabilized, I would say. It is a huge administrative burden, but we have 100% compliance for all our hospitals reporting to the federal government. We also have 100% compliance on the post-acute and psych side. So we have information on admissions, we have information on occupancy of various types of beds, we have the COVID share of occupancy, the COVID share of ED use within each hospital, and then we have some data on staffing shortages, PPE, and supplies, although it's not as rich of a database as the rest of what I mentioned. Despite all this, we as a state recognize there were still questions that we could not address using the data that was being reported to the federal government. And so some of those data gaps we have filled with state-specific questions. For example, as you all know, and Dr. Skornovac mentioned, post-acute care transitions very quickly became obvious as a bottleneck. So we now have twice weekly reporting on the supply of post-acute beds of certain types, and then acute care hospitals, on the other hand, report on demand. So we're able to look at supply and demand issues on the post-acute side. The psych data, as I'm sure the audience is aware, we have a ballooning ED boarding crisis in behavioral health, and we would love to have a more complete picture of that sector of the healthcare system in terms of capacity and occupancy. We do have some of it from freestanding acute care hospitals and psych units in acute care hospitals, but there are chunks that are missing that really we need to complete the picture. And we continue to have some data challenges on the SNF and assisted living and other parts of the care continuum that would really help complete the picture. So those are the data gaps. And then the other couple things I wanted to mention, there are a lot of things that would be nice to have, but we have to strike this balance between administrative burden, especially at a time like this, and the need for that data. So examples would be demographic data on COVID patients, detailed supply and PPE burn rate data. I know there's a survey out in the field with all the hospitals seeking some of that information. I think it's being done in conjunction with DPH and MIT, trying to understand PPE burn rates and other details. Cumulative data on admissions of various types would be nice to have, but we are, as I said, trying to strike this balance between we have these federal mandates, but we don't want to now start adding state requirements that overburden our hospitals. And then some nuances that the state is attempting to understand. So they're now collecting information on suspected versus confirmed COVID cases and the conversion rate between suspected and confirmed. So just yesterday, the state reported that they found that the rate of conversion of suspected cases to confirmed is 17% in non-ICU settings and 27% in ICU settings, which is the first time we actually got that snapshot of what actually happens to those suspected cases and what is the magnitude of that. They're also collecting information on folks that come in with primary COVID versus incidental COVID. And I think the idea is to try to understand whether how much of this is more testing and how much of it is a true resurgence and hospital capacity dynamic. So yesterday they reported that in the non-ICU setting, 60% of cases that are confirmed COVID are actually admitted for COVID symptoms, whereas the number is 80% in the ICU. So this is information we didn't have as recently as 2 weeks ago. And as I believe Kirsten mentioned in her opening statements, we are all now focused on understanding the resurgence and what it would look like. How will it differ from the first surge? And how will that impact resource needs, including staffing and PPE? And I think the underlying sentiment in all of this, in an attempt to understand the resurgence, is that I think there's general consensus that the kind of wholesale shutdown of elective services that we had in the spring is not desirable from a patient outcome perspective or from a financial sustainability of the healthcare system perspective. So we are trying to make sure we understand the data, we track the data, we report out the correct data that is meaningful, and at the same time set up mechanisms for sharing this data and for localized decision making within regions so that we can load balance patients and avoid overwhelming the healthcare system. So back to you, Jeff. Those were my remarks.
Thank you so much, Dr. Perry. The work that your team has done is just incredible. And so we all thank you for that. It makes me think, hearing your perspectives and your point of view from the state level and the challenges that you faced, what the state of data analytics must have looked like in the hospital systems that you were working with. And for that, we turn to Dr. Dunn. Dr. Dunn, what kind of projections were leaders in the health system looking for in those earliest days? And how did you wrangle the data that you did have to create those kinds of projections?
Yeah, Jeff, and appreciate everything that, that Dr. Perry and her team had done, because it was really helpful to have the ability to reach out and find out what was going on at the state level as we were looking at the information that we had at the hospital and system level. So that relationship was really important to help level set our experiences and what it may look like. We were fortunate at Mass General to have already in existence what we call healthcare system engineering, which began over 14 years ago as a collaboration with MIT Sloan School of Management. And what it employs is operations research techniques and mathematics to model opportunities for improvement in the challenges that we face in healthcare. We had just finished up the previous year modeling a future state of the allocation of all the beds in our hospital and had just employed that. So we were already moving in a direction of balancing out the appropriate resources we need for the different patients. Didn't anticipate that we were going to turn on a dime and now apply that to what we were facing with COVID, but we're able to do that. And so early on, the questions that were being asked by our senior leaders and asked to consider was, are we going to be impacted much as like was being reported in New York and Italy? Those were the two areas that had gone before us that had enough data that we could take and create models to understand what the impact may look like based upon different sensitivities of impact about what they had experienced. So they want to know, were we going to have enough resources? Would we have enough ICU beds? Would we have enough ventilators? Would we have enough other supplies such as PPE? And did we have enough staff, both in numbers as well as in specialization for the ICU, the general care, the ED, and all the other areas? So those were components of the models that we began to create. We did it not just for Mass General, but we did it for all of our hospitals across the system, both as singular entities, but also as a system. And working with others across the city, we compared those outputs with those that were being created at other institutions to try to get the future direction for at least a week or two out. We were fortunate that we were able to predict what the future state at Mass General and the other hospitals in our system would look like about a week out, such that we could provide a recommendation to the senior leadership and our incident command team to say, we're going to need another ICU in 1 week. That allowed us to then consider what floors of the general care would we want to convert over to an ICU. It gave us time to plan to get the training of the team to function in a novel environment that's not normally used as an ICU, to balance out the resources of physicians and nurses so that you had at least an appropriate complement of ICU experience mixed in with other people that were willing to work in those environments in new ways. And I'll give you an example of that. We converted over one of our general care floors in one of our new buildings to be an ICU. We don't have the same connectivity in those floors as you do in an ICU for the ventilators. So we'd had to take some of our researchers to sit in each of the rooms to be the monitor for the ventilator because we could not get connectivity. We learned that we were going to need to do that, so that week lead time allowed us enough to be able to plan for that type of change in job description for the research community that were willing to help out in a clinical way that they hadn't had to in the past. So it really was the prediction of all the needs of the changes in the volume of the research, of the resources that we needed, that were the questions that were being asked. And I'm going to turn it over now to Dr. Safavi to tell you how we created those models and what the information from the output of those models was used for and how it was communicated.
Thanks a lot. So I think, it was a real evolution, what models we developed, how we developed them and how we used them. And we were really learning as we were going. And I think the first set of models that were really important for us as a system was really epidemiologic models that were intended to tell us what are some of the severe, mild, and sort of moderate peak occupancy scenarios that we expected in the pandemic in the first wave. That was really the impetus for a management exercise, really, of coming together around the table, operational leaders from around the system in 10, 11 different hospitals to talk about how are we actually going to meet the need of a worst case scenario. Because as the data developed and as we projected out based on actual cases, we realized we're probably more in a mild to moderate of these scenarios, but we needed maximal lead time and planning if we were not going to go underwater with a severe scenario. And so at the very beginning of the pandemic, in the end of March and very beginning of April, we did this exercise. And it was really important to have, I think, as much of a data-driven approach to that really helped people put their nickel down on, I'm going to meet this target capacity in these different ways. I'm going to convert these units, I'm going to repurpose these, and so on and so forth. And so, and one of the things that exercise really opened up for us was the where the system might be vulnerable in certain places and where we really need to work together to share resources, whether it's CVVH machines for renal replacement, ventilators, or whether it's moving inpatient transfers. And so, so that was the first sort of set of models. The other piece in the first wave was really that we found useful was benchmarking our trajectory as a system and as a hospital with the best known experience of hospitals that came before us. And that was really in Italy, with a lot of the hospitals that publicly report good data on hospital occupancy in the Italian national health system. And because of that reliable and transparent data, we were able to understand, are we on a more severe path as some of the regions in that country were, or are we on a more mild path? And that benchmarking helped us get a better understanding of where we were headed. The models ultimately evolved to a point where we had enough COVID patients in our hospitals that we were able to understand, what is the ICU utilization rate of these patients? What's the length of stay? What's the sequence of general care ICU utilization, such that we could build a more sophisticated model where we are actually simulating hospitalizations that haven't happened yet, as well as the remaining hospital stay of those patients who are currently admitted. And that lets us project that's this 2-week projection where we chose 2 weeks because we think, beyond that, there is more variability and uncertainty. But we think for 2 weeks forward, we have a better sense of what the occupancy is expected to be based on these simulation models. And that's also enough of a time frame to make operational moves that we need to. And in the first wave, that included things like converting a general care unit to an ICU before you urgently needed that capacity, because you can't just open a new surge unit, that ICU that's never had ICU patients before, and slam in ICU volume. That's just not a safe or acceptable situation for anybody involved, including the patients. So that's been one of our that's where our model is today. Really, we're leveraging all the different patients that have come before in terms of what their length of stay and other characteristics are. And then the last thing I'll say is we monitor a few other things. So we monitor geographic hotspots in our area from the first wave and their number of hospitalizations in the system. We look for accelerations there. We monitor the facilities, SNFs, and otherwise post-acute care facilities that refer to us and look for hotspots there. We also are more sophisticated now in the types of COVID patients we're monitoring in our hospital system. So now you'll have a patient get admitted for a head bleed who actually, that's why they're getting admitted rather than COVID respiratory failure, but they happen to be COVID positive. And those mean two different things in our modeling and in our operations. So we track that as well.
Thank you, Dr. Savavi and Dr. Dunn. The work that you've done to date is just a really powerful testament to the way that models are helping us get ahead of surges in clinical care demand and capacity demand, and helping you even all the way to the point of re-architecting your floor plan, retraining your staff, making sure that the people are in the right place, the beds are where they need to be, the equipment is by the bed, the researchers have been retrained, everything is established and ready for the surges that your models are predicting. I think about the future, and we've spent a good deal of time talking about phase one and the initial models and how we got to where we are today, but we hope to be in a state where vaccinations are going to become available. We're going to have another phase of this pandemic in which we are distributing and inoculating the population. Are there models that health systems should be thinking about today and working on today to prepare for what's to come still with this pandemic?
I'll take a first stab at answering that, and then I'll let Kian add on to it. I think what's important for us in operations of hospitals to understand is what is the relationship with the information that we hear about testing positivity rates in our communities, and what does that mean for what we need to do differently in preparation for the patients that are coming through our doors needing care in the hospital. What we have seen through the recovery, and we continue to see, is a disconnect between the rate of positivity testing in the communities and the hospitalizations. I know that we've heard from others that they have seen some relationship to that. We have not. And as Kian had mentioned, we have been following the 5 or 6 major hotspots that drove a lot of patients to us during the first wave. And they too have been having increased test rates. But none of that has panned out to mean increased hospitalizations, either general care or ICU. So I think something that we need to continue to understand is what is that relationship, and then are there ways that we can better refine the information that's coming out of the testing rates to look at subpopulations that maybe we are seeing an increased rate of hospitalizations in certain groups, but it's being masked by the higher level of testing for patients that are never going to come through our door. So for instance, in the Boston area, we're inundated with a lot of colleges. There's a lot of testing going on in those environments with very young populations. Those are not the ones that are going to be coming through our doors for the most part. Is that overshadowing some of the lower level numbers, but more important groups to focus on that really are having an impact or are being impacted by the spread of the virus in the community that we need to pay attention to better. We're trying to look at that ourselves, but it would be an important thing for us to be looking at as a state. And I know that there's a lot of discussion, as Dr. Perry had mentioned, about looking at the data differently. But I think that's one of the key linkages that we still don't have a grasp on that we should work on.
Excellent. Now, we've talked about the state and health system level analytic strategies and how they've matured, the direction that they're headed. Dr. Skornvakia, I was hoping that we could talk about the work that you've done to support post-acute care coordination. So as these patients are recovering and they're ready to be discharged, how are analytics supporting acute care delivery, And how are new data points being implemented within clinical workflow to help frontline care providers make decisions both about care delivery in the hospital and about that post-acute care discharge process?
Yeah, so I think it's important to understand that most of us who are on this call probably are involved in Medicare ACO, and one of the largest strategies in a Medicare ACO is developing very strong relationships with the post-acute environment, right? So really, it's a lot about preventing folks from heading to the emergency department, therefore more likely to be admitted. So how do you make sure that when you discharge a patient appropriately at the appropriate level, when they do get discharged to home, how can you leverage transitional care and longitudinal care and care across the continuum to kind of prevent that reemergence back to the emergency department and the like? Now, early in the crisis, it was very evident that healthcare systems as a whole, with the brick and mortar systems that we have set up, don't traditionally have direct connection links clinically to these skilled nursing facilities. We work with them, we send patients to them, but if you really sat down and talked about warm handoffs, collaboration, and things like that, it may not exist in a really strong way. Luckily, our director of the post-acute has really built some of those relationships well before this crisis ever hit. And, you know, like most folks in ACOs, we have a preferred skilled nursing facility network, home health, and then now we're working on hospice. And really, the point of that is when you develop these networks, you can work on clinical workflows collaboratively between skilled nursing facilities and with all the inpatient settings to really work on a particular topic. And I'll put sepsis as a classic example. It is not uncommon for people to start having signs in a skilled nursing facility, whether it's poor discharge plan or not maybe exactly the right timing of the discharge or the appropriate level of discharge, but they'll start emerging with some clinical symptoms that are hinting towards sepsis. Skilled nursing facilities traditionally are not set up to recognize that, much like a SWAT team or a code team or a crash team in a hospital would recognize clinical things that would hint towards we have to intervene now. Not a lot of post-acute settings are set up that way. So how could you work on something like that collaboratively? And really, these network development models is how you get at that. You have these cross collaboratives to work on a topic where you can share workflows and best practices. And really all that hard work lended itself to trying to have some semblance of what the heck are you going to do when a virus comes to town and totally blows up the normal workflows, right? So early on in that process, just simple things of getting PPE. The skilled nursing facilities really had no leverage, and so now they're trying to deliver care with providers with limited PPE in an environment where it's obvious that that is the highest risk population. And they don't have enough boots on the ground knowledge of their local healthcare environment to understand where they can get help and who to ask for help. So just having those conversations was step number one. And really step number two was setting up some of these facilities as a discharge destination for COVID positive patients once they've gotten beyond the critical phase. So most nursing homes did not want to accept COVID positive patients back to their nursing home and put others at risk. But could you deliver a destination where you could actually set it up where it is a COVID centralized post-acute setting, which we tried to do and actually were successful in doing, where you could have hundreds of patients be discharged out of an acute tertiary care center during that improved phase after they're critically ill and starting to recover, because we knew that population in the 70, 80-year-olds was going to linger and take some time for recovery. So leveraging that was kind of step number one. As things calmed down through May, June, and July, we really turned our focus towards advanced care planning and understanding how maybe not necessarily a poor job we've done, but not a fantastic job of addressing these issues before severe illness develops. And really, how can you build palliative care and advanced care planning initiatives to deliver those services, whether it's in the hospital, whether it's to a patient's home, or to the skilled nursing facility itself. We have a very large portions of the ACO members that were sitting in a skilled nursing facility, having had no serious conversations about advanced care planning, likely to develop complications and end up requiring redeployment back to the emergency department and getting admitted again. So I think most of our focus during the summer was on advanced care planning and building some technology, using our data to kind of share with those nursing facilities, develop a workflow and set up some pilot projects where we could deliver remote telehealth consultation for palliative care. So what does that really mean? That means physically having, much like telestroke in the ED or EICU, where you actually have the capability to look in on a patient. How can you set it up where you actually have monitors on a workstation that's mobile within a skilled nursing facility that has the capability to do a face-to-face consultation with a palliative care provider in the nursing home when the nursing home does not want providers walking through the front door? You know, and for the bulk of them, there was no access. You know, the medical directors might be able to go in, but consultative services was essentially shut off like a fire hose without allowing a lot of those providers in the door to begin with. So we're just finally launching some of those initiatives. We've done a lot on the telephone, but actually using Care Agility and some of the other technology, because Zoom, although as a health system, we leverage Zoom Health as our telehealth platform, and all of us definitely spend a lot of time working on this. And I know our next panelist is going to spend a lot of time about how primary care has been impacted by this. But I do think that leveraging the right platform, and I'm looking it up because I never remember. So we're using a telemedicine cart called a Cisco DX80 as the actual device that is wheeled around the nursing facility. And Care Agility is the platform that allows a PC to be used by our palliative care providers to kind of deliver out to those community-based facilities to do that consult with the family, patients, nurses, social workers, everyone who's out in the nursing home itself. So that's kind of where we're at. Rona Shawshuk, who is our manager of all this work, has really worked with MHA extensively over the summer months, really working on this post-acute environment. I know she tells me about all the great discussions that MHA has pulled together to kind of have these discussions. And really, one of the strengths of what we do is try to bring the detailed data that they can't gather themselves back to them. And if we can define the population on our end, use our data analytics claims data and give them feedback on how things are going, which is going to be much harder for them to mine their own data and look for trends. We try to do that on a very regular basis. And that is probably one of the biggest things that is the glue of our network, is they realize by participating collaboratively with the other SNFs and long-term care, LTAC, internal rehab, and they get to see some of the data and they get to share in that data and identify opportunities specifically related to COVID or some of the other chronic conditions. So there'll be a lot more to come. I think that is really just the tip of the iceberg. But I think heading into fall, heading into numbers that are marching in the wrong direction, I'm pretty confident our team feels we're in a much better place to help them as a health system, actually help the skilled nursing facilities and actually provide some clinical support in the face of these small, sometimes family run and owned facilities that are not nationally big corporations, to help them wade through recovery as well as what's coming down the pike.
Great, thank you, Dr. Skornbach. It sounds like from the work that you're doing, it's really the acute telehealth ability to deliver care at a distance, as well as the analytics strategy and the shared data analysis that's sort of been the keys to success in that acute to post-acute care collaboration space. Dr. Johnson, we turn to you. I know we've just touched the tip of the iceberg on the advanced care planning issues that we've seen during this pandemic and some of the overall integration challenges that are being faced by primary care. And I'd love to understand more from you how analytics are being used to empower patients. And I know that you have a presentation that you'd like to present to talk through some of these concepts. So I'm going to go ahead and share that now.
Great. Thank you so much. And I am going to build a little bit on what Dr. Skorbaka just shared with us around population health and using data to ultimately, as I said earlier, to help our patients. So when COVID pandemic kind of bore down upon us and was shining a spotlight on our system around, and you can advance to the next slide, around what was working and what was not working across our system. At the same time, we had a sudden influx of seriously ill patients. And my hospital colleagues on this call will know that they were ending up in the hospital, ending up in our post-acute facilities, ending up in primary care, urgent care, really ill with an illness we didn't understand and without advanced care planning. We didn't know what the patient's wishes were, and particularly by the time they were in the ICU, and unable to, as we know with advanced care planning, unless you have it documented, you don't know what that patient's wishes were. Advanced care planning has been a long-standing issue in our health system. How do we make sure that it occurs, and how do we document it, and how do we put it in the right place, and how do we find it when we need it, right? So certainly the pandemic highlighted all of those issues. We had emergency situations, and we wanted to be able to bring together the disparate data and also the teams from, I just, kind of outlined all the different places where people were ending up, and how do we use data and analytics to help improve the situation. So on the next slide, you'll see we put together a task force, which really involved, it was very multidisciplinary. It involved people from our ACO performance network, our primary care, from our hospital, from our IT, from project management. We actually started off with a pretty small crowd, and the first 3 or 4 meetings we kept on saying, well, we're missing this person, but so by the time we got going, it was a larger crowd, but I think really necessary. As you look at the slide, there was a whole bucket of work to do around provider training, a whole bucket of work of, all right, this is a problem. How are we going to identify patients? I'm going to talk about that more in my comments. How do we communicate to patients? How do we let them know that we want to be able to do this? How do we operationalize this? And ultimately, how do we leverage our EMRs, and how do we document it appropriately? So with that, and how did we use the data analytics? You'll see on the next slide. I'm not going to focus today, and happy to talk and share offline with anybody, how some of the work we did around provider training and patient communication. But in particular, we said, well, we need to use our data to identify patients who don't have advanced care planning and we don't know where it is. And how do we also, in the time of COVID, when suddenly, particularly in primary care, we weren't seeing patients, as we know, back in March and April, we shut everything down. So we knew patients were at home. We knew they were worried. We knew they were scared. And we knew this would be an opportunity not only to outreach them around advanced care planning, but also to check in and see how they were. So it really became a very positive exercise. Once we identified patients who we wanted to use telehealth, as Tom just described, a new modality that we also struggled with forever to kind of get upstanding. We kind of did that overnight with telehealth, and we'll never go backwards from that. To how do we use that to then reach patients at home and do some advanced care planning, and then get it in the right place, so wherever that patient ends up in the health system, we'll know what their wishes are. So on my last slide here, you can see kind of how we began to put together our predictive analytics. If you move to the next slide, the predictive analytics, and then our performance metrics. We still have a lot of work to do, but what is important to realize is how much predictive analytics we have at our fingertips. And this is just a list here within our own health system. And I'm sure all of you have many of these tools. We all have registries. We use Milliman, we use Optum, we use Arcadia, we use our EHRs, Epic in particular. With BILH, we have multiple EHRs that we pull upon, Epic and Athena and OMR. But Epic has a COVID risk computation score, which we found very useful for, has an end-of-life care index. Arcadia has a particularly good ARC score that identifies our high-risk, high-need patients. Ultimately, everybody needs advanced care planning, but we needed a place to start. So we used a lot of these different tools to identify our patients. And then we went back to our primary care, particularly in the early days of COVID, when we did have a lot of our staff at home who had some bandwidth at that time to make these outreach calls, began to do that. And we also then worked with the providers on teaching them how to do some of these advanced care plannings over telehealth, different than doing it in person. And then we measured it. We measured patient engagement. We followed how this worked for them. And we really had a very positive outcome of being able to reach people. We learned from people that many of our patients were happy to begin to do this. With the telehealth calls, we could have the patient there and we could have their family members right there in their living room having this advanced care planning conversation. So very successful. I think we have lots of opportunity to scale it and to continue to figure out which of these predictive analytics work best for us. So I'll pause there.
Great. Thank you, Dr. Johnson. Sounds like across the board, significant uptick in use of telehealth to get to our patients across a very challenging environment, analytics to understand where those patients are, which patients need to be prioritized, and even underlying our approach to moving supplies, moving resources, reorganizing the very floor plans of our care delivery. And all of this really being underpinned at the state level by data teams like Dr. Perry is making sure that we're running a tight ship and we're perpetually improving, and that the data that we need is going to be available to us. I want to move forward into some of our closing thoughts. And for that, Dr. Perry, I'd like to pass it back to you. What has MHA learned as a result of this that will influence public health reporting and analytics strategy beyond this pandemic?
Thank you, Jeff. I would say 3 broad lessons as an association that we've learned. I think that as we head into a resurgence, our first lesson is that we really need to continue to make sure that we collect frequent bed capacity data in a systematic manner with clear definitions, so we have a complete picture and it's consistent and it's complete. And the complete part is the part that we're still working on, because we do have a lot of data on acute care hospitals, and as I talked about earlier, there are still data gaps, and we need to continue to work on those data gaps if we're able to have more of an impact on patient care transitions. Which brings me then to my second lesson that I think we've learned as an association, is that while we recognize the need for data should not be collected just for data collection's sake. Especially in a pandemic. So as I mentioned, there are some new data elements that the state, for good reason, is looking to collect, that we have been told require chart abstraction. Now, if you have 5 COVID patients, you can do chart abstraction, but if you have 50, it's going to be a real challenge. So we have to kind of find this balance between all the nuances we would like to know about COVID, but recognize the constraints and strike a balance. And in addition to that, then take the data. So I think I mentioned, I don't know if I mentioned earlier, that one of the best parts of our partnership with the state, and the fact that we're using the state as the avenue to submit data to the federal government, is that we receive all the data for all the hospitals at MHA, which we then send out as raw data files at the end of the day, every single day. So all hospitals have data, their own data, everyone else's data. They can see psych data, they can see post-acute, they can see hospice, behavioral health. Every data element that we receive, we send back out, so people can do error checking, trending, research, whatever they need to do. So that's been possible because of this partnership with the state. But not just that, we take that and convert that into reports that are meaningful to our hospital leadership. We just take 3 key metrics up until now: ICU, med surg, and ventilator. We're working on adding more, but the greater point here, the lesson here, is that collect data that is meaningful and then turn it around in the form of reports that leadership really needs to see. And then finally, my third lesson is this partnership that I keep talking about. Our partnership with the State Command Center, DPH, has been invaluable throughout this process. And the collaboration between acute care hospitals themselves and acute care hospitals and the rest of the care continuum has been indispensable. There's so much that we would not have been able to know or do if we didn't have that. So this has been a monumental challenge. And I think that the healthcare community as a whole has risen to this challenge. And with the state government's partnership, we have positioned ourselves well, I think, from a data perspective, going into a resurgence. There's still work to be done, but we've come a long way, and there's several people that had several stakeholders that had a role in that. So as we move into the resurgence, we hope that we can have more localized decision-making, data sharing within regions, and similar to what, the kinds of groups that were set up in Boston that Dr. Dunn mentioned, we're hoping we can set up those kinds of regional groups for more rapid data sharing. So those are my three. Thanks, Jeff.
Absolutely, thank you. Dr. Dunn, any lessons learned or closing thoughts?
No, I would just echo what Anu just said and reinforce the idea that I think we need to better understand, what the population health numbers are and how they relate to what we in the hospitals need to plan for in the coming future. And to the question I think that somebody had asked or brought up, what is the vaccination impact going to be? And for that, we're not going to know until we get into it. As Kian had mentioned, we can look out about 2 weeks. Anything further in that, the variability in the environment that we're in is too high to know further than that. But hopefully with some stabilization as the vaccine may bring, we can better predict further out.
Great, thank you, Dr. Dunn. Dr. Savavi?
Not a lot more to add, just, based on some of the comments and questions about the other downstream impact of COVID, which is, some of the non-COVID patients who truly plummeted, in terms of coming to the hospital during the first wave, and what are the downstream consequences of that this year and many years to come, potentially for those individuals. How is our healthcare system going to better understand what that means so that we can anticipate how we need to realign yet again to accommodate those future needs? I think is going to be really important. And it's probably the next body of work after hopefully, we put this behind us.
Great. Thank you, Dr. Savavi. Dr. Skorvaka.
Yeah, I think one of the more recent things that our team is starting to think through is having more opportunity to educate our patients in what testing really means and who should and shouldn't be tested. I would say one of the biggest things that has occurred during this little bit of a resurgence is that the frantic nature of the calls has picked up. And since testing is so much more readily available, it's giving them a false sense of safety and reassurance when they test negative without really understanding the timing of the testing and the need for quarantining. So I think that we all need to be a little bit more diligent, even in understanding ourselves, when to test, how to test, the interval of testing, and the discrepancy between returning to work, with a negative test or traveling out of state, coming back and getting a negative test. So we're not exposing lots of folks with asymptomatic patients that haven't been tested in the right intervals.
Excellent. Thank you, Dr. Skorvaka. Dr. Johnson, you want to close us out?
Yeah, I would say, lesson learned, there's nothing like a crisis that can accelerate problem solving and helping us figure out issues that we've stumbled over and haven't been able to. And so we're there, particularly with telehealth. And a lesson that I would like, is that we don't lose steam. We don't lose sight of that. And we continue to build upon what this crisis allowed us to solve for, but continue to work and move ahead on that.
Excellent, thank you. And thank you to our panelists and our attendees. And now I'll pass it back to you, Kirsten.
Great, thank you so much. Again, I also just want to echo all of our thanks to the panelists. What a distinguished group, and this is one of the better webinars I've attended. It was just full of great information all along the way. And if you're watching the webinar, we are recording it. We'll send out the link to everybody, and feel free to disseminate. This is great information for hospitals getting ready for what's to come. So I'd also like to thank you very much, Jeff, for moderating, and Forrester, and also a great thanks to Dimensional Insight for making this webinar possible for us. And with that, we will close the webinar. Thank you so much.
Thank you all.
Have a good day.